Groote Hospital is celebrating the 10th anniversary of its HIV-positive to HIV-positive kidney transplant. The decision to transplant organs from HIV-positive patients was not taken lightly. The surgeon, Professor Elmi Muller, needed the backing of the medical community. That was in 2008. Fast forward 10 years, and there's a waiting list for transplants. Well, Professor Muller spoke to my colleague, Tulasizwe Simelane, about the groundbreaking work.
The program started in 2008, and when we started using HIV-positive donors, we were the first medical team in the world to use HIV-positive donors. And as a result of our work, not only did policy and procedure change in South Africa, but it also had an impact on other countries. For instance, in the USA, the HOPE Act was accepted in 2015, which allowed patients from the USA who have HIV to also receive HIV-positive kidneys. So, yes, the work was groundbreaking. We did publish it in the New England Journal of Medicine when we did it the first time, and it had a major impact on policy and procedure elsewhere in the world.
So what were the considerations on your mind? I mean, given that, you know, the two patients were HIV positive, so was the issue of reinfection a factor that had to be considered, or perhaps other complications? What did you have in mind?
Well, there were many things to consider. At the time, we weren't sure how well HIV-positive patients will do when they are on immune suppression, and that was one consideration. We also weren't sure whether they will be more likely or less likely to reject their kidneys. So those were considerations we had to take into account, but using an HIV-positive donor, of course, brought in a second viral strain into this patient's body. And having a second viral strain means that potentially that new virus could flare up. And for us, that was a major question at the time. How well will patients do if they get a second viral strain? And would this become a problem, especially in the light that these patients will be immune suppressed? So when we started the study, we had none of those answers, but as time went by, we've been doing a lot of investigations. We've done clinical viral loads on these recipients, as well as viral sequencing on them, and we now today know that the second viral strain isn't such a big problem. But at the time when we started, this was all questions that had to be answered.
So I imagine that you probably took some steps to mitigate the impact, particularly as you talk about a second viral strain. As we know, the HIV virus, the way that it behaves and the various strains that do manifest. So I imagine that as doctors, you considered what you could do to mitigate the risks that could have been associated with the introduction of a second viral strain for the recipient.
Absolutely. It was very important to select the donors very well. Remember, this is a deceased donor program, so all the donors in this program were patients who donated their organs after they became brain dead. And these kidneys had to be assessed in terms of their quality, but also we had to have some information about how well the donor's virus were controlled before he donated, and whether this donor's kidney was exposed to any antiretroviral therapy. And having that information made it easier for us to make a decision then, how would we treat our recipients? Do we need to change the medication that they were on? Do we have to make them change them to, for instance, a second-generation antiretroviral therapy drug, or whether it was safe to keep them on the first-line treatment that they were on? It was also very important for us when we selected out our recipients to make sure that they were stable on antiretroviral therapy with a reasonable CD4 count. So all those different factors had to be taken into consideration when we selected out both the donor as well as the recipient for the transplant.
But now, Prof, I understand that not everyone was as excited about the prospect of taking a huge leap forward in as far as, you know, organ donation for people who are living with HIV is concerned. In fact, I'm told you almost lost your job. How did that come about?
Well, I think At the time when I started this program, it was, of course, not a very well-known phenomenon yet that HIV-positive patients could get a transplant. And the policies and procedures in the Western Cape was pretty much that HIV-positive people were not eligible for dialysis, and the basis for this was that they were not going to make good transplant candidates. And when I started the program, I had to change these views, and many people had a very conservative idea of how these patients will do. Remember also, it was in a time when South Africa's antiretroviral therapy has just come in. Patients were still struggling with issues, political issues around the disease, having access to treatment. So the political situation in 2008 was very different to what it is today. Furthermore, when I started the study, I just wanted to get patients, give them a treatment option, wanted to get them better, and because the Department of Health was also worried about cost and worried about the fact that I've started these programs where patients suddenly are now getting transplants. They were very worried that it's going to open up a can of worms, that patients will get very ill, that they won't do well with immune suppression, potentially going to flood the medical system with a lot of problems. And I think generally hospital managers, as well as some clinicians, were scared that this program is not going to be successful.
So it harks back to those times that some would say were perhaps part of the period of madness in as far as our understanding as a country, certainly in as far as policy is concerned around issues to do with HIV. Talk to me about the survival rates of patients who have received, kidney donations, HIV-positive patients receiving kidney donations from HIV-positive donors. That seems to be improving. That must excite you.
Yes, it is a great thing. We are, at the moment now, we're 10 years down the line, but of course we have patients that are different time points after their transplant. So if you look at the survival rates, for instance, our 5-year survival rate, it comes around about 85%. Our 3-year survival rate is over 90%. And it means basically that we are able to treat and prevent problems for patients who receive organs and are HIV positive much better as time is going by. We understand much better what the issues are. We understand that they have a very dysregulated immune system rather than a completely immune suppressed system, and we're much better able to prevent and treat rejection in these patients. So if you look overall at survival rates for HIV positive patients in my program, it's more or less similar to the survival rates of HIV negative patients. And that is very exciting because when we started, we weren't sure if these patients are going to do as well as HIV negative patients.
What's next then for you to explore, Prof. Muller, is the potential and the possibility of HIV positive donors, donating organs, including kidneys, that are then received by a recipient who's HIV negative. Is that one of the areas that are potentially something in the near future?
So in Johannesburg, Professor John Botha did recently a child who was HIV negative and received a piece of liver from his mum who was HIV positive. And the basis for this decision was that the child had no other options and wasn't able to access an organ in time. So the child would have died if he didn't get the transplant. And I think if something like that happens, most of us would choose to rather than receive a life-saving organ, even if we do get HIV. However, in the broader context, we do have a long waiting list with HIV-positive people waiting for organs. And I do believe that taking the HIV-positive organs away from this specific patient population group isn't in general the right decision to make. I think we need to continue to give these organs to HIV-positive patients on the waiting list. And because in our country we have so many patients who are positive, our rates are around about 20% in many areas in the country, I think it's possible for us to just continue the HIV-positive to positive transplant program, but expand it into all the other organ groups.
So just finally on that point, and I think that's something we don't think about, Prof, the issues to do with organ donation for people who are HIV positive. What's the picture there in terms of, I mean, you touched briefly on it, that there's a long waiting list. How long is this list? And also which
Yes.
organs usually are people needing donations of?
So if you look at the waiting list in general, we're sitting with lists as big as 3,000 patients waiting for kidneys in South Africa. If you just look at the HIV-positive population, we probably have about between 70 and 100 patients waiting for kidneys. And this list grows because more and more people get renal failure, and our donation rates in South Africa is not enough to keep up with the ongoing disease that's in the country. So it's very important for the public to consider whether they would like to become organ donors. And I think it's a very enriching experience now for people with HIV to know that they can also be organ donors and that they can also make a difference in this way. And certainly in our experience at Groote Schuur Hospital, many of the donor families were so excited when they were able to donate their organs of their loved ones despite the fact that they had HIV.
All right. Thank you so much for that and your insights. And keep up the good work there, Professor Elmi Muller of Groote Schuur Hospital, talking to us there about the issue of organ donations, particularly kidney donations between HIV-positive donors and HIV-positive recipients.